Thank you, and thank you for this opportunity to talk to you a little bit about our experience. So, Chanie and I are both actuaries at Discovery Health in Johannesburg, but we're part of a broader team. You can see some of their names there on the screen. We're the ones who are lucky enough to be with you here in person this afternoon. I'm really hoping that some of them are online at 5:30 a.m. in Johannesburg to help us with any of the challenging questions you're going to throw our way. So our presentation is going to be covering a sample of the extensive work that was done by our actuarial teams across the group related to COVID-19 analytics, a lot of which we have published to try and support the development of the learnings from COVID. This, of course, was a period where we had to be really agile as a profession and respond in a time of crisis and rapidly unfolding risk, and also understand how this shifts the landscape that we're working in at the moment. So hopefully we'll be able to contribute to your thinking about that. So just for some context, for those of you who are not as familiar with our market, Discovery Health is the largest medical scheme administrator in South Africa. We administer schemes covering just over 3.5 million lives. That's out of a population of around 60 million. And we're also part of the Discovery Group, which is a broader financial services group. We have life cover, short-term insurance and banking, also and investments as part of our group. So just in terms of what we're going to be covering today, I'm going to start with some context of COVID-19 and how it impacted South Africa and shaped our response. And then Chanie's going to talk a little bit about the methodologies that we've used that underpinned a number of the published research articles. And she's going to give an overview as well as some of the results. Then I'll end off with some comments on the emerging trends. And of course, we're looking forward to your questions and comments. So COVID arrived in South Africa in early March of 2020, and we went into the hard lockdown on the 26th of March 2020 in order to try and flatten the curve. One of our big concerns with the respiratory virus is the impact that it would have on 8 million South Africans living with HIV, and also the associated burden of multi-drug resistant tuberculosis that we have in our population. So flattening the curve was really critical for us because we had to scramble to get our already stretched and straining healthcare system ready for the consequences of a pandemic. So from a healthcare perspective, though, Discovery Health had already introduced what we called the WHO, World Health Organization, outbreak benefits. So interesting following on from the previous presentation. So we introduced this in March of 2020, and it covered treatment and testing. So that was actually used later as a template for the prescribed coverage. So the medical schemes actually were mandated to provide that coverage as we went into the pandemic. So I thought it would be interesting to just compare how the South African experience unfolded compared to what happened here in Australia. And I thought this might give some useful context for the analysis that we did. So a key point to note here is that these graphs are from the Our World in Data website, which you may have forgotten that you used every single day in 2020. And they of course refer to reported cases. So this is the data that we know about, right? And so I'm going to come back to that a little bit later. But basically in South Africa, you can see we had 4 big waves and a smaller 5th wave. The graph on the left, I'm hoping I'm getting the lefts and rights correct, is the case counts. So it shows that for Australia, the longer and harder lockdown meant that cases hit much later. But importantly, our case fatality rate is much higher during the first 3 waves. So the pattern of deaths, again, this is confirmed deaths, reported deaths, it was much higher count of deaths. So just to give you a sense of it, our case fatality rate was in hospital. So our in-hospital case fatality rate was 28.8% during the beta wave, then 26.4% during the delta wave, and then 21.4% during the much more drawn-out 3rd wave. And then it dropped to 10.7% during the Omicron wave, which I might add was not our fault. This reflects the effects of the fact that we could better understand the treatment what was working as we moved through the pandemic, and of course as the variants evolved and shifted. So I noted that the graph on the previous slide was based on the confirmed and reported mortality. So as the pandemic unfolded, it became apparent to us that the reported deaths were not giving us the full picture of COVID, of all the COVID-related deaths. And in South Africa, the Medical Research Council tracked excess deaths by measuring the total of reported deaths from natural causes in excess of the upper confidence interval of the longer-term expected trend. So these excess deaths are measured over the upper confidence interval of the longer-term trend. So as these escalated in the first wave, it seemed that around a third of excess deaths were included in the reported deaths. So only a third. While there was initially some concern that this difference could be attributed to the economic devastation of lockdown, which I'm sure was experienced around the world, the pattern of deaths that emerged, these excess deaths, and you can see them there in the graph, followed the waves of the pandemic really closely. So the majority of deaths can really be concluded to be associated with COVID-19, those excess deaths. And this pattern of around about a multiple of 3 times the reported deaths persisted through the pandemic. So this phenomenon of excess deaths is, of course, not unique to South Africa, and the extent varies across the world depending on whether the wealthier nations, of course, have more advanced reporting. But it certainly does point to the need to focus on improving mortality reporting generally as part of an effective crisis response. So now let's focus on Discovery Health's experience and analytics. So we found in the South African context that we at Discovery Health, we were fairly uniquely positioned to be able to provide valuable analytics to support the country's response. We had this comprehensive data set, a large pool of lives that were covered. We had their health status. We had information around their vaccination status later on when we could get the vaccines, which Chanie will touch on. And we also had information on their access to or the use of wellness and the health analytics. So we also were able to partner with the Medical Research Council, as I mentioned, to give us a bit more access to research and epidemiological expertise. So an important first step was ensuring that there was access to meaningful data. People often talk about the data pandemic as well as the COVID pandemic, and this, of course, was the case. So we used various tools to bring these metrics together, and we built various dashboards. I'm sure those of you working in healthcare had a similar experience. These were made available to key decision makers across the organization, and we also were publishing this data. So an early application of the rapid analytics was the development of what we called a resilience index for our covered population. So we were monitoring the admission rates and fatality rates over the first few months, and in fact we were reasonably successful as a country in delaying the onset of that first wave, so we didn't have a huge amount of data to work with, but we were able to start using that analytics to develop a better understanding of the risk factors. And so by June of 2020, we'd actually enhanced the WHO's resilience index with additional factors from our own data, and we were able to understand who was most at risk. And so what we did was we implemented a project where we distributed pulse oximeters to the high-risk lives, and that helped to detect silent hypoxia before severe symptoms developed. So this is a first case study, really, of a number of studies here where numbers do save lives, and we published this analysis, and this kind of demonstrated that as a focus for our covered lives, we could also share this information and ensure that by the public having access to this information, we could save lives across the country. So we built an information portal, and it became a trusted resource for many of the lives in the population. So this was part of a broad partnership of sharing information and sharing data. Some other examples, you can see there the COVID Alert app which we built on and, of course, made available across the population to alert people in terms of when they were in contact with a confirmed case. And of course, the vaccine rollout program itself was a great example of public-private partnerships in a resource-constrained setting, where we were able to use this analytics to help with the distribution planning. So I'm going to hand over to Chanie, who's going to take us through some of the published analytics.
Oh, thank you, Roseanne. So from August 2021, we published articles unpacking vaccine effectiveness, durability, and also the impact of physical activity on these outcomes. And as Roseanne mentioned, we partnered with various stakeholders, such as the Department of Health in South Africa. And I'm going to take you through a bit of the methodology underpinning these studies. So we chose to use two robust methodologies. The one was a test-negative control design, and the other one was a clinical twin design. And this test-negative design is commonly used to assess the effectiveness of flu vaccines. And how this works is that we look at all people who tested for COVID-19, and therefore through that we are able to compare their outcomes. And then the other approach that we used was the clinical twin design, which is a population cohort study. And I'm going to take you through that in a bit more detail because that has a lot of real-world applications. So in our case, the population of interest that we were looking at was the vaccinated population. And we were able to then bootstrap this population with replacement 500 times so that we could get a representative sample. So what we do is within each bootstrap, we randomly match each life to a similar comparator life based on sex, age, region, chronic conditions, and number of admissions in the prior period for people who didn't have a vaccine administered. And once the match occurs, the comparator is no longer eligible to be matched to anyone else in the bootstrap population, and we call these matched lives clinical twins. We are then able to assess the difference or residual in admission rates between the vaccinated population and the clinical twin at different points in time for each bootstrap population. The bootstrapping allows us to produce confidence intervals around the residual admission rates between the population and the clinical twin. And where the confidence interval passes through 0, there's no statistical significance in residual admissions between the population and clinical twin. And you can see that this is the case for the time period shown, where you can see those confidence intervals pass through 0. But if we look at further on in the graph, those admissions do have a the population has statistically significantly fewer admissions, and through that we can say that the vaccine is effective in reducing admissions. So this is the methodology that we used for various analyses to investigate the effectiveness in a real-world setting. And I'm going to take you through a few of those different case studies. So firstly, in South Africa, the vaccines only became available just over a year after the outbreak, and frontline healthcare workers were given priority to the J&J vaccine. So what our analysis showed is that in terms of reducing admissions and ICU admissions and deaths, the vaccine was effective. Another thing that we had to look at in South Africa was looking at whether both J&J and Pfizer were effective because both were available in South Africa. And what we found is that both J&J and Pfizer were effective in protecting against severe illness during the Omicron variant. Another thing that we looked at was adverse events potentially caused by the vaccine. And we saw that 3 conditions were found to have statistically significantly, there was a statistically significant risk of occurring post-vaccine, But these conditions occur more frequently following COVID-19 and are easily treatable. Another thing that we wanted to look at is to see how long the vaccine is effective for, and to basically see the waning effectiveness of COVID vaccines. And we saw that there is actually rapid waning of vaccines. And from our data, we see that a booster vaccine should be administered around, say, 4 months after the initial vaccine, or that the vaccine should incorporate variants of concern to maintain protection. And then lastly, another thing that we looked at was the effect of physical activity on vaccine effectiveness, because we do have, as Roseanne mentioned, a sizable cohort of physical activity data. And we saw that physical activity can act as a possible enhancement to the immune boosting effect of COVID-19. So having gone through just our analyses on the vaccine, we also wanted to look at the post-pandemic consequences in terms of the people who had COVID-19 and what this could mean in the future. So as Roseanne showed, we did see that there was excess mortality because of COVID, and we can see that this was actually more pronounced for males versus females. And once we remove COVID deaths, we can see that the line becomes flat. So all of the deaths that we were seeing in 2020 and 2021 can be attributed to COVID. And then what we also wanted to look at is now, if someone has had COVID, do they have a higher risk, do they have a high mortality risk? And what we've seen, and we'll see it actually, I can go through the slides quite quickly, we went through mortality, admissions, and getting new chronic conditions, is we saw that while a person has COVID, they have an extremely elevated risk of mortality, admission, and also getting new chronic conditions. But post-COVID, within 2 to 12 months post-recovery, we see that the risk of mortality, admissions, and getting chronic conditions greatly reduces. So you can see it in these graphs, you can see it in the admission graphs, and you can see it in the chronic conditions, where we looked at diabetes and hypertension specifically. And we saw that in recovery, there's an 8% higher chance of contracting diabetes and a 3% higher risk of contracting hypertension. But the point that we felt is that because the risk is so much lower once a person has recovered from COVID-19, as healthcare funders, this isn't something of great concern, but should rather be monitored. But something that we did think that might be of bigger concern is this COVID-19 symptoms. So what we did is we sent out a survey to, we had 7,000 respondents, and we saw that of the 7,000 respondents, headaches, breathlessness, and sleeplessness were the most common symptoms, and this affected their ability to perform activities of daily living well after their recovery post-COVID. So this may have an impact on insurers who are insuring against people doing activities of daily living. And then lastly, what we also were looking at is just screening rates. There have been a few sessions on this, and we looked at oncology. So what we saw is that during 2020, and I guess continuing after, there was a great drop in screening rates for all types of cancer. We chose the top 4: cervical, breast, prostate, and colorectal. And then what we saw is that this actually translated into cancer being detected at a higher stage. So you can see that the proportion of stage 1 in 2020 is much lower than in other years. And this is of great concern for going into the future. So this actually bolstered or created an innovative benefit that we made called the Wealth Fund. And what the Wealth Fund aims to do is use excess solvency built up during the pandemic through lower healthcare utilization, and for a limited period offer screening to our members, which will then bolster up the rates and also create awareness of healthcare needs. Now Roseanne will just conclude.
Thanks, Chanie. I'll just wrap up with a few closing remarks. I think you've all experienced this, that we've seen that COVID has kind of changed the landscape of health delivery. And there's certainly exciting opportunities to build on in terms of what we have learned about effective delivery of care. So we've seen, for example, hospital treatment has shifted from the bricks and mortar facility settings to the field hospitals, and of course also to the home setting, where real-time monitoring is actually improving health outcomes when it's applied in a clinically appropriate way. Similarly, with pathology, we've seen a shift from the labs to drive-throughs, and now rapid testing, again helping us to filter so that we're using our healthcare resources more effectively and appropriately. And of course, we've taken this rapid leap forward in the use of telemedicine and other digital health tools to support delivery of care. And this is really significant for middle-income countries like ours, where opportunities to expand access to care are really sorely needed. And again, an area where sound analytics can really play an important part. So we've whisked you through some of the analytics that we've done and how they've contributed to rolling out treatment in South Africa. We've talked about the vaccines, as well as addressing how they've addressed mortality and severe illness risk during COVID, and how COVID seems to be affecting mortality going forward, and also how we've applied these excess funds in terms of trying to promote the early detection of risk. We're always willing to learn from what the data is telling us, and there's no doubt that our post-COVID world looks different. And as actuaries, we do need to start adapt to this kind of disruption and really learn from these historic trends to make sure that when that next pandemic arrives in 2035, we're ready to face it and manage the risk. So this just gives you a sense of the team of people who are behind this effort. We're just the lucky ones who get to present it to you, but they're the ones who really deserve the appreciation for the rapid response and the analytics that we've presented today. Thank you.
Thanks, team, for another very comprehensive presentation. So we've got some time for questions. If you can put them in the app, that'd be great. We actually have had some come through, so I'll kick off with those. First question is, is your analysis applicable only for the subset of South Africans with private health insurance, or have you verified the results with the public system as well?
Yeah, so one of the things we learned from this analysis is the value of public-private partnerships, so not just in healthcare delivery, but also in the analysis. So one of the big advantages for us in terms of working with the Medical Research Council was then to get access to the expertise who could then benchmark our analysis against what they're seeing in the general population. But the value, and I think it's interesting to make the comparison to the experience in Portugal, the value is that while we were dealing with our internal data, we had a complete view of people, because they tend to be using either the public system or the private system in this case. So we had a complete view of their healthcare journey, as it were, during COVID, and then that could be extrapolated, appropriately extrapolated to the population. As I said, I mean, the burden of disease differs, in the covered versus the uncovered population. But in the case of COVID, of course, as we subsequently learned, it was not actually HIV. There's elevated risk associated with HIV, but it wasn't. It wasn't the crisis that we actually had feared back in March of 2020.
Just a similar question that we got on the Portuguese experience. How did the non-COVID claims experience differ during the pandemic?
Yeah, so we had a big drop-off in the use of elective treatment. To the extent that we also had projects to try and support the private practitioners who experienced this drop in their income levels. Although a lot of them were also helping to support the triage. But so we built up this the surplus. Now our medical schemes are mutual funds, so the surplus for the lower levels of utilization then remained in those funds, and we used that in two ways. The first way was that we delayed contribution increases in the subsequent years. So even though our utilization levels were recovering, again with some fairly important analytics and modeling, we then delayed the contribution increases as a way of giving surplus back to the members, during a time when people were in economic hardship. And then the second way we've looked at giving the benefit back to people is through this wealth fund, which is a set of screening benefits that people can access. And the advantage of that, of course, is that it also puts more money into the healthcare sector.
And also just to add on that, we've been monitoring closely which type of admissions are reverting back to pre-COVID levels. And the two that we're seeing in terms of elective procedures is cataracts, pretty much they're actually exceeding pre-COVID levels, and spinal surgeries.
Just maybe building on the wealth fund is another question relating to that. So how was it received by policyholders, and how long do you think it'll run for?
So it's going. I'll ask the second part first. 2 years. So we've set out as 2 years. It's being very positively received in terms of people, feeling now that they have sort of freer access to this set of benefits. And certainly we gave quite a lot of discretion in how they can use it. But it, with all of these things, with new benefits, it takes a while for people to actually get the hang of how to use it. So I think that's why it's actually quite a good thing that it's spread over 2 years, because hopefully then people will actually. I mean, it's ironic that you do these projections and but you actually want people to use those benefits, because we know as well that even though it's a way of giving some of that surplus back, it's also an investment in the health experience going forward. If you want to add.
Maybe time for one or two more questions. So there's one more in the app here. Is Discovery still holding reserves for the claims catch-up, or is that not considered necessary at this stage?
Yeah, so the medical schemes, of course, have a requirement to hold a statutory minimum solvency level, which we're still above and projected to even remain above that, even with the wealth fund. So we are projecting the recovery. So we're pricing for that recovery of the experience based on the recovery that we see unfolding. And as Chanie said, we're seeing different patterns. So we're dealing with this changing landscape that you see some types of utilization recovering above pre-COVID levels, and others that seem to be stabilizing below that level. So that dynamic in terms of ongoing analysis and appropriate pricing and reserving, but always being open to listen to what the data is telling us, is really important in this climate. Chanie?
And I guess also to add on that, it's quite interesting in COVID, potentially there's overutilization in the healthcare system, and COVID has in some cases actually closed that. So for example, if you look at, say, in the renal space, say the South African admission rate is much higher than in other countries. And we saw that in the COVID period, that admission rate was kind of reverting to an international rate. And now the question is, during COVID, that rate is probably too low, but we want to keep it lower than it was pre-COVID. And that is the case in multiple disciplines or multiple types of admissions. So it's kind of trying to find the balance between keeping levels at almost at a COVID level, but allowing for it being depressed because of COVID, but definitely not reaching the pre-COVID levels.
Great. Well, I think we're out of time now for this part. So thanks, Chanie and Roseanne, for your presentation.